We are just going to start our 35th online teaching class under the banner of Up-Aroi. We have already covered breast cancer, cervical malignancy, head neck malignancy. Now this is done for the genito-urinary. For this, we are covering first prostate cancer, and this prostate will be covered into 3 classes. So we are very fortunate to have Dr. Kirti ma'am with us for this first class. For moderation, I would like to invite Dr. Ashutosh Mukherjee. He is the head of the Department of Radiation Oncology, MPMC, Banarasi. Dr. Ashutosh, it is over to you.
Thank you, ma'am. Good evening to all our colleagues, students, and Dr. Kirti. I take the pleasure of inviting Dr. Kirti Srivastava. She is a professor of radiation oncology at K.G.M.U, Lucknow, and she will be talking on the principles and philosophy of management of prostate cancer. Over to you, ma'am. Thank you.
Thank you, Ashutosh. Then good evening to everyone. And actually, this prostate cancer was not my area of interest, because we normally don't see these patients much in our day-to-day practice. But when Surabhi asked me to talk about this, I actually accepted this and tried to read about this. And while preparing for this lecture, I came to know very new things which were we never thought about. And actually, I would be trying to share that with you all, because as sir told, there is a lot of overdiagnosis and entirely different kind of scenarios there with prostate cancer. So I'll be trying to cover that, and let's see how much I can transfer the information to you all. So I'll be talking about the role of PSA screening, role of screening basically, and then deconstructing the Gleason's and the risk categorization, and then decision making. So this is the overall scenario of the prevalence and incidence of prostate cancer worldwide. And you can see that it is more common in the Western world. And fortunately, in our country, the incidence is quite low. And this is in UK, it ranks first in the incidence, and the mortality it is second. And in US, it is third commonest, and the mortality is fifth. And in India, the incidence is 12th amongst all malignancies, and the mortality is 14th. So we need to understand the problem, what we will be discussing in next 1 hour. That is, it's a kind of a different malignancy, and there is no clear-cut evidence that screening saves life till now. Risk of overdiagnosis and overtreating is there. Available radical treatments have significant morbidity and an adverse impact on quality of life. With increasing age, the benefits of early detection reduce when deaths from other causes increase. And there is a minimal impact on the overall survival. Mortality as such is very low in this particular malignancy, and effective hormonal and other treatments are available. Methods for monitoring progression is also available. We can monitor it with the PSA levels and other parameters. So we can call it as a medicalizing the normal. A person who will be living a normal life, by overdiagnosing, we are actually medicalizing his normal life, and he will, throughout his life, then he will be seeking help from the medical personnel. So overdiagnosis occurs when the cancer is destined not to progress, or because the rate of progression is so slow that the patient dies of other causes before it produces symptoms or signs. So that is what the definition of overdiagnosis is. And this happens many a times in this particular malignancy. So here we can see that this is the onset of preclinical disease. And this is the time when the disease becomes evident on its own if we don't screen it and detect it earlier. And this is the lead time. So if we detect through screening, So this is the time which is known as lead time, and the death occurs here after, which is the non-cancer death, maybe due to some other reason. So this is known, if this happens, then it is known as, it is not known as overdiagnosed, which is happens in most other malignancies where screening is actually effective. But here what happens is that the preclinical disease is there, and if we screen and detect the disease, and during this lead time, the death occurs because of some other reason. So this scenario will be known as overdiagnosed. So there are 4 possibilities actually in the natural course of the disease. There can be spontaneous involution. The subclinical disease is there, but it involutes in itself. And the reason could be the lack of VEGF or a lack of telomerase or a host immunity. But the second scenario can be, the possibility is very slow growth. Patient dies of other causes before it causes symptoms. And the third scenario would be the slow growth and may lead to signs and symptoms and death after many years. And the fourth one is the fast growing lethal course. So the first 2 scenarios, they are known as pseudo disease. The disease is there in a subclinical indolent form. And if we diagnose that which comes in the overdiagnosis, in this scenario, there is no threat to the patient. Even if the subclinical malignancy is there, there is no anxiety and psychological stress of the disease because the patient doesn't know that he is having it. And there is no unnecessary treatment in the first 2 scenarios. And the lead time is many years leading to detection of cancers which never could become symptomatic. In a patient with limited life expectancy, a small cancer that grows rapidly is also an overdiagnosis. So in where the life expectancy is less, we need not to screen that patient, or there should be no hurry to diagnose this malignancy in that particular patient. This occurs due to, this overdiagnosis can occur due to if we go for a screening or we perform any test unrelated to screening for some other reason and we come across this malignancy and it is diagnosed unknowingly. Now, with increase in sensitivity of CT scans, MRI, etc., there is a risk of identifying many indolent cancers. So we know that technology is evolving and the sensitivity of CT scans and MRIs are increasing day by day. And therefore, we can diagnose that we might see something abnormal in this gland, and we try to detect it, and then we come across the malignancy. And now this affects the patient's sense of well-being. Unknowingly, the disease was detected, and that is going to affect the patient's sense of well-being, physical and emotional health, relationship with loved ones, because it has an impact on quality of life. And the health insurance purchase also gets affected because you are diagnosed with a malignancy. There are issues with this health insurance issues. So the facts are that the prostate cancer is an important concern for men. Screening with PSA and DRE can detect prostate cancer at an early stage than it would be found if no screening is done. It is difficult to predict who will benefit from treatment and who will die from unrelated causes. Treatment can cause urinary, sexual, and other health problems. There is a possibility of false positive and false negative results as well, potentially causing unnecessary testing, anxiety, or missing the disease. Unnecessary biopsies may lead to pain, anxiety, and possible complications related to biopsy. Not all men with prostate cancer require treatment. And here we can see the latent prostate cancer, the incidence is quite high with the increasing age. However, the clinical prostate cancer is very low with the increasing age. And while doing screening, we tend to detect these malignancies which are not clinically evident. With the increasing age, the incidence increases. So does the survival improves? Lead time bias, early diagnosis at preclinical phase of disease, and the length time bias, possible selection of more favorable, slow growing tumors with inherent long survival times. So this is the survival data bias, which will happen. So what can be done for this? There are 4 strategies can be adopted. Develop clinical and patient tools to help inform decision making. Focus on development and validation of markers that can differentiate between minimal and significant risk disease. Decrease treatment for minimal risk disease. Intensify treatment for highest risk disease and target preventive measures in this particular group. The more people are overdiagnosed and treated, the survival statistics improves, giving popularity to screening. This last line in red is very, very important. The more we perform screening, the more we will detect the subclinical disease, which will automatically have better survival. And this will affect the survival data. We will say that we are performing screening and that's why the survival is improving. And this is how the screening will get popularity, and more people will undergo screening if they depend on this data. So this is how we see that, the patients who are at high risk, that is the BRCA mutations, the first degree relatives having prostate cancer, or the ethnicity, African Americans, they have higher incidence and the aggressiveness of disease. So if we perform screening in this particular group, there might be that we less overdiagnose. However, in the normal risk population, there is no clear evidence that screening saves life so far. Although having these risk factors also don't give the license of performing screening these patients. So we have to depend on the individual patient's parameters. And there is no clear-cut evidence that screening saves life. If against the screening, we have these facts that there is overdiagnosis, overtreatment, 50% will not need treatment at all. Radical treatments have side effects, which have quality of life issues, psychological impact. Whereas for screening, we have these facts like incidence is high and shall increase in future. As I talked earlier, the more we screen, the more we diagnose subclinical disease, these incidence will increase. And this shall increase in future with the increase in the longevity of the human being. And the more and more the average age increases, there will be more of the increase in the incidence. Diagnosed only in advanced stages. If we don't intervene, then mostly the disease is diagnosed when it is very advanced, and there we cannot think of cure in most of the cases. Now, treatment-related side effects are decreasing with increasing technology. So day by day, the technology is improving with the surgery as well as in the radiation techniques. And thereby the side effects are decreasing. So as we say that over-treatment affects the quality of life, this might decrease in future. The trials on which the evidence is based, they have limitations, and I will discuss them in future slides. So the US Preventive Services Task Force recommended that population screening for prostate cancer should not be adopted as a public health policy. But recently they have updated their recommendation statement, changing it from a grade B, which is recommendation against PSA-based screening for prostate cancer, to grade C, which is the advocating for an individualized approach to screening. So we have certain trials, the PROTECT-T trial, which is prostate testing for cancer and treatment trial, which included 82,000 patients performed in UK. And they had, this is the number which were screened, and 2,664 they were detected having prostate malignancy on PSA screening. And they were randomized to active surveillance versus radical prostatectomy versus radiotherapy. Active surveillance was based on PSA levels only, and more than 50% rise in the PSA level led to the review and further investigations. RT was given 74 Grays 3D CRT and the hormonal therapy. There was no difference in mortality. However, disease progression was higher in active surveillance group. The observations in this trial were the patient group was relatively younger. Mortality reported across all three groups were very low. Over 50% assigned to active surveillance underwent active treatment in 10 years' time. However, 44% were spared of any treatment, those who were in the active surveillance group. Active treatment protocols have evolved since the conception of this trial. Urinary and erection-related side effects were more with the radical prostatectomy, whereas radiotherapy was associated with more of bowel-related side effects. Both the techniques have evolved since then, and the CHIP trial has confirmed the importance of hypofractionation to be a better alternative with less side effects. The limitations of this trial were that they developed 2 decades ago, did not use multiparametric MRI, older surgical techniques were used, in IMRT and brachytherapy was not used, and less than 1% were African Caribbean only. Strengths that the randomized study of all PSA detected prostate cancer, standardized treatment pathways, and regular follow-up till 10 years was done in this group, in this trial. There is another important trial, which is European randomized study of screening for prostate cancer, ER-SPG group 4, and they enrolled 600 PSA screened patients, and the 2 arms were radical prostatectomy versus observation. The mortality was less than 20% at 15 years, and in low risk group, it was 10%. And PSA screening reduces prostate cancer mortality. The conclusion was this. The number needed to screen to prevent 1 case of prostate cancer from dying from prostate cancer is, however, substantial, as well as the number needed to treat to prevent 1 prostate cancer death. The main drawback of PSA-guided prostate cancer screening is overdiagnosis, with estimated rates of 49 to 58% and related overtreatment. Another PLCO trial, after 13 years of follow-up, there was no evidence of a mortality benefit. This is another very important big trial. And for organized annual screening in the PLCO trial compared with opportunistic screening, which forms part of usual care, and there was no apparent interaction with age, baseline comorbidity, or pre-trial PSA testing. So the difference between the 2 major studies was that PLCO, there was no difference in survival benefit, screened and non-screened arms at 7 or 10 years, and no reduction in incidence of advanced cancer. Whereas in ER-SCP trial, there was 20% reduction in prostate cancer specific death at 9 years of follow-up in screened group, and 1,410 men screened and 48 men treated to prevent 1 mortality from prostate cancer, as I discussed earlier. So screening seems to have increased the burden of low-risk cancers without significantly reducing the burden of more aggressively growing cancers, and therefore has not produced the anticipated reduction in cancer mortality. So we are diagnosing cancers in early stage, we are treating them, and therefore there is no effect on the overall mortality data. So this is the ESMO guideline published in 2020, which the recommendation for the final recommendation for screening in this guideline is that the population-based PSA screening of men for prostate cancer reduces prostate cancer mortality at the expense of overdiagnosis and overtreatment, and is not recommended. level 1 evidence. Early PSA testing, baseline PSA followed by risk-adapted follow-up, can be offered to men more than 50 years, men more than 45 years with a family history of prostate cancer, African Americans more than 45 years, and BRCA 1 or 2 carriers more than 40 years. There we have level 3 evidence. We can perform screening. Testing for prostate cancer in asymptomatic men should not be done in men with a life expectancy less than 10 years. Now coming to the risk categorization, PSA, we all know it's an organ-specific and not the disease-specific parameter. It can be elevated in BPH, infection, infarction, instrumentation, massage or DRE, sports, sexual activities. These all lead to transient raise in the PSA levels. MRI, which is multiparametric MRI, it should not be offered to people who will not go for radical treatment. This should be very clear that even when we are thinking about cure or the curative radical treatment, then only we should go for this. Should be offered to patients with suspected clinically localized disease. If we already have the evidence that the disease is beyond the gland, it has invaded the adjacent areas, then we should not go for this. Reporting should be done with 1 to 5 Likert scale. Those with more than 3 should go for biopsy. If the clinical suspicion of prostate cancer is high because of a high PSA value and evidence of bone metastasis identified by a positive isotope bone scan or sclerotic metastasis on plain radiographs, do not offer prostate biopsy for histological confirmation only, unless this is needed as a part of a clinical trial. Because we already know that the disease is advanced and performing this MRI is not going to help. Now coming to the Gleason scoring and grading. The Gleason grading system is recommended in all prostate specimens in adenocarcinoma, except showing treatment effects. Like if the patient has been treated by hormones and all, then maybe it is affected. Now it is based on the glandular architecture. The Gleason score is the assessment of most common and second most common pattern, assigning a grade between 1 to 5 to each pattern. Now, Gleason's grade is sum of these two patterns reported as the Gleason score. Example 3 plus 3 is equal to 6. The Gleason scores range as follows. The score 2 to 4 is well differentiated. 5 to 7 is moderately differentiated and 8 to 10 is poorly differentiated. Now here we can see the pattern of the glands in the histopathology. Small uniform glands, they are well differentiated. There is more stroma between the glands or distinctly infiltrative margins, then that is moderately differentiated. Irregular masses of neoplastic glands or only occasional gland formation, that is all poorly differentiated or anaplastic. Now, it is recognized that contemporary Gleason scores can be grouped into 5 prognostic categories. These grade groups have shown significant correlation with outcome. This grade grouping is referred as ISUP grade, which is International Society of Urological Pathologists. The grade group should be reported in parallel with the Gleason score. When patients are told that they have a Gleason 6 out of 10, it implies that their prognosis is intermediate, despite the fact that Gleason score 6 is the lowest grade currently assigned. So this is the grade group which is currently being used, and Gleason score. And the definition is that if the less than or equal to 6 is the grade group 1. Only individual discrete well-formed glands are there. Gleason score 7, 3 plus 4. Predominantly well-formed glands with lesser component of poorly formed fused cribriform glands. And here, the score is 7, here also and here also, in grade group 2 and 3, both. The Gleason score is 7. However, the outcome and the prognosis is different in both these two scenarios. Here, They're the predominantly poorly formed glands with fused cribriform glands with lesser component of well-formed glands. And here it is vice versa. And therefore, the outcome is different. And that is why the group is different. This is grade 2 and this is grade 3. Here in the grade 4 group, the Gleason score is 8 in all these 3 scenarios. However, there is a difference in the pattern. And in group 5, the Gleason score is 9 to 10, and they lack gland formation or with necrosis, with or without poorly formed fused cribriform glands. So these new grade groups were formally accepted by the 2016 WHO and the College of American Pathologists for the foreseeable future. Grade groups would be reported alongside the Gleason score. A Gleason score 6 out of 10 prostate cancer would be in the new system B grade group 1 out of 5. Patients could be reassured that they have a grade group 1 tumor on biopsy, that is the lowest grade tumor possible, which is most cases can be followed with active surveillance. Whereas when we say that it is grade 6 Gleason score, they think that it is something intermediate. It is not the very lower variety or the benign variety. And that is why this grouping is becoming more and more common. And these are the core biopsies which has to be taken from the various areas of the gland to represent the whole gland, the histopathology, because it can vary in different areas. Now, these are the risk groups, the K.G.M.U risk groups, which are in the 3 categories: the low risk, intermediate risk, and the high risk. And PSA less than 10 and Gleason score less than 7 or ISUP grade 1. And the clinical stages C T1 to T2A. Intermediate risk, PSA is 10 to 20 and Gleason score is 7 or grade 2 or 3. And the clinical stage is T2B. Here the PSA is more than, in the high risk group, it is more than 20 and score is more than 7 to 10. And the grade group is 4 to 5 and the clinical stage is C T2C. So, and any PSA, any Gleason score with T3 or T4 disease or N positive disease, any grade group, it is all locally advanced disease. Now coming to the decision making, how to decide what treatment to offer to a particular patient. So once we encounter an elevated PSA in a patient, we should perform a repeat PSA testing after some time. And if it is still raised, then we should go for MP-MRI, considering the factors that the life expectancy, the overt overt clinical disease, like if we already know that the disease is advanced, we should not go for this MP-MRI. And if the Likert score is more than 3 with the MP-MRI, then only we should go for biopsy, otherwise not. And we have to consider other factors also. If the patient is, we have to discuss with the patient whether we should go for a biopsy or not, whether he is interested in the treatment, and many factors are there which we have to consider. And if it becomes positive, then we have to stage the disease and the risk categorization has to be done, whether it is a localized disease or advanced metastatic disease. And if it is a localized disease, then which risk it is, intermediate, low or high risk. And then further staging for these 2 groups can be done, not for the low risk group. So for after diagnosing a patient with prostate malignancy, we have 3 options. We can keep the patient on watchful waiting, or active surveillance, or active treatment. It will all depend on the life expectancy and the risk of disease. and the aggressiveness. Now, what is the difference between these three modalities? Yes? Somebody wants to ask something?
Ma'am, we will take question after
Please
this.
continue, ma'am. Please continue.
Okay. So, so watchful waiting is the focus will be managing of symptoms only. And in active surveillance, the focus is to delay or avoid active treatment. And active treatment is the immediate treatment, which we have to do. The risk of prostate cancer progression is very low through high in combination with short life expectancy. Here it is low to intermediate, and here it is intermediate to high. Treatment intent is palliative in the watchful waiting, and in other two it is curative. Follow-up is patient specific. Here it is predefined schedule, and in the active treatment it is after the treatment. Life expectancy is less than 10 years in watchful waiting, and in other two it is more than 10 years. To be more precise, the difference between active surveillance, intent is curative and here it is palliative. Follow-up, I've already, assessment and markers used are, here in active surveillance, we can use DRE, PSA, rebiopsy, MP-MRI, and here it is not predefined. Life expectancy we have discussed. Aim is to minimize treatment-related toxicity without compromising survival. And here it is minimize treatment-related toxicity. This is to be done for low-risk patients and can apply to patients with all stages, watchful waiting. So the physician's perspective, this is also very, very important for us. The doctors begin to fear the possibility, even the probability that they are doing harm while trying to do good. Like if they are offering active surveillance, they might be harming the patient. So this fear is there. Healthcare systems put enormous emphasis on screening and other preventive interventions, at least in part because there is more money to be made from the healthy majority than from the sick minority. So there are a lot of pressure from various sectors to go more and more for screening, diagnose patients early, offer them treatment, and you can understand many things beyond this. Now, the informed decision, offer people with prostate cancer information tailored to their own needs, because the way this information is presented to the patient is very, very important. And here comes the role of the physician who's dealing with the patient. The information should be given in such a way so that he gets help in taking the decision. Find out the extent to which the person wishes to be involved in their decision making, and ensure that they have sufficient information to do so. In our scenario, most of the time patients say that, Doctor, you take the decision. Whatever you say, I will follow. So it is all on us then to give take proper decision and offer the treatment if needed to that particular patient. There are certain nomograms which can be utilized to assess the risk and take decision. Discuss the treatment options with their impact on the quality of life. So the side effects of the treatment, the radical treatment which we will be offering are very, very important and should be clearly explained to the patients and to the carers also, and the other family members. So the protocol for active surveillance is year 1 of active surveillance. Every 3 to 4 months, measure PSA could be carried out in primary care if there are agreed shared care protocols and recall systems. Throughout active surveillance, monitor PSA kinetics. At 12 months, DRE should be done by a healthcare professional with expertise and confidence in performing DRE. In a large UK trial that informed this protocol, DREs were carried out by a urologist or a nurse specialist. At 12 to 18 months, multi-parametric MRI should be done. At year 3 and every year thereafter until active surveillance ends, every 6 months, measure PSA could be carried out in primary care if there are agreed shared care protocols and recall systems. throughout active surveillance, monitor PSA kinetics, could include PSA density and velocity. Every 12 months, DRE should be done by a healthcare professional with expertise and confidence in performing DRE. This is the same. It should be done by a urologist or the nurse specialist. So active surveillance should be done only when the Gleason is less than 6 or PSA is 11 to 15. 1 or 2 biopsies, maximum 30 to 50% cancer, PSA density is less than 2. This is the nuances. And the trials were done with the active surveillance cohort of patients. And we see that the survival is more or less same, cause-specific survival. Another trial by Hamdi et al., and there was no significant difference among the treatments offered. And this is the localized prostate cancer. And if we have a low risk disease, in the guideline, we have this option of active surveillance or the watchful waiting. And this can be offered without any legal problems because the guideline offers this. And in intermediate risk group also, we have this option of active surveillance. This again is the detail. I'm not going into this. Do we have time?
Yes, ma'am. We have time.
Okay. So for the low risk patients, offer active surveillance to patients with a life expectancy more than 10 years and low risk disease. The evidence is strong. If a patient has had upfront parametric MRI followed by systematic and targeted biopsies, there is no need for confirmatory biopsies. Patients with intraductal and cribriform histology and biopsy should be excluded from active surveillance. Perform a multiparametric MRI before a confirmatory biopsy if no MRI has been performed before the initial biopsy. Take both targeted biopsy of any PI RADs more than 3 lesions and systematic biopsy if a confirmatory biopsy is performed. Follow-up strategy, performs PSA assessment I have already discussed this. Same here in intermediate risk. We can offer radical prostatectomy and RT also. So this I'm not going to discuss here. For high risk, we have to offer the radical treatments which are here, and active surveillance is not offered here. Thank you so much for your patient listening. Surabhi, to you now.
Thank you, ma'am. Dr. Rohini, if you have a question, you can put it in the chat.
But I wish to thank Dr. Kirti for addressing this topic in such a nice manner. So many things have been clarified. Thank you, ma'am.
Thank you, Rohini. I hope I could do justice to this topic, although it was a lot of philosophy in this.
No, ma'am, actually, it does put into perspective the present day, practices. A lot has been explained very nicely by you. I really liked it. Thank you so much.
Thank you, Rohini.
Ma'am, I have one question. What is the basically ideal time gap after digital rectal examination and the serum PSA?
Exactly, I don't know, but it is raised for a few days probably. So at least it should be repeated after a week maybe, but I'm not very sure about this.
The second question is single value of the high PSA is basically acceptable, or we should advise the repeat PSA?
Yes,
because
I have shown in my flow chart that once you get a raised PSA, you should repeat it after some time. And if it is still raised, then you should go for further investigations.
Dr. Ashutosh, any question?
No, ma'am, nothing from me. But I would like to thank Dr. Rohini, Dr. Kirti also, because this is a part which we during our studies quickly skip over and go into the main locally advanced prostate and radical artery. So this part usually gets left over. So thank you, ma'am, for addressing this part.
So that was new for me also while preparing this talk.
Thank you so much. Definitely, this was very difficult. I can say that a philosophical part. So it must be very difficult to prepare this. Only one question from my side, ma'am, left. Transperineal or transrectal route? Which would you prefer for the biopsy?
Transperineal is the current recommendation.
But in most of the practice, we basically go for the transrectal. I don't know why.
Because maybe this is now coming up and it is recommended that we should go for transperineal biopsies. DRE through the rectal, probably it is easy for the urologist to perform, but the results are not good with that technique.
Shalin sir is here. Actually, he was traveling.
No. I'm very much here. Can you hear me?
Yeah, we can hear, sir.
Right. So I've messed my system in some way that I cannot use the video, but good, I can at least use the audio. So first of all, Dr. Kirti and colleagues, I have to say that considering that we do not see and treat so much prostate cancer, this dissection has been marvelous. Importantly, I think the important things that you have highlighted are that prostate is not one disease. There is a continuum. The second thing is that clearly there is scope for overdiagnosis, even without us realizing. When we see the odd patient and somebody says, "Doc Sahab, why not do a PSA test, or why didn't you order a PSA test?" The third thing is that having ordered a PSA test, a completely new story unfurls of anxiety and treatment. And of course, you did point out about overdiagnosis because there is a lead time bias and a length time bias, and the fact that there is no impact on survival. That's the other important thing. And finally, when we come to the treatment aspect, we will touch on that. But basically, regardless of what we do, things can get messed up with a lot of treatment. So thank you very much for bringing this point. The second thing I appreciated was the dissection of the Gleason score and putting the grade scores in place and explaining it. This was really important. We forever get confused. It's worth reminding. And that's really it. So I think we're done. And if there are, I hope there's some questions in the chat box. Unfortunately, I cannot make out from my screen. But if there are, I think we should take it. Otherwise, we can then, I leave it to the moderators and Dr. Surbi as to how they want to conduct the rest of it, if at all necessary. Thank you.
I think there's no more question. Ashutosh, can you see?
Yes, ma'am. Yes, ma'am.
So we can conclude this talk. Dr. Rashi, you want to say something or any question from your side?
This topic is really discussed.
So we can conclude, Ashutosh?
Yes, ma'am. Yes, ma'am. Let's conclude then. We don't have any more questions today.
So thank you so much, Ashutosh, for moderation. Thank you, Kirti ma'am, for such a nice talk. And thank you, Salin sir. Thank you, Rashi. And thank you all the participants here present.
Thank you, Surbi. Thank you, sir.